I'm posting the links to our various channels in the chat box. This is it. So we are already live, and this is the 66th Pain Journal Club, and I'm going to just share my screen now. Please type yes in the chat box when you can see my screen now. I hope all of you can see my screen now, and I think we would now begin. So just type yes in the chat box if you can see the full screen. So guys, come on, type yes in the chat box so that I can begin. Yes, good. So thank you, Dr. Shasmit. Others, please type yes in the chat box so that I can just begin. So today we are going to have a very special topic, neck and upper limb MSK ultrasound. And we have some exciting speakers and faculties. So let's begin the session. Before we begin, we'll have a short introduction. Pain medicine in the world over has got diverse issues and variable standards, different learning requirements, different offerings for as far as training is concerned. And of course, money and time is something which prevents most pain physicians from getting more and more knowledge and information, because it's a super specialization and you don't have a set job profile after you complete your fellowship programs. So Mumbai Pain School was formed as an initiative of Pain Spine Wellness and Pain Relief Center with a vision to provide online education with the help of social media like Facebook, Instagram, Twitter, and others. So we are basically providing online learning and on-demand videos with both free and paid content. But in addition, we also have hands-on workshops, and we are very fortunate to have expert faculties from all over the world. It is said that the best teachers, they teach from the heart and not from the book. And a journal club is nothing. It's just like a club. The only difference between a club and a journal club is that we are going to critically evaluate the recent academic literature, which is based on a defined subject. And of course, attendee participation is very important. So guys, those of you who are attending on Zoom or on Facebook, on YouTube, wherever, so please type your questions and be very responsive so that we can understand what you are thinking and participate. It is very tough to be regular, so every week I see old faces dropping out and new faces coming in. So try to be regular. We have a fixed time, 8 p.m. every Fridays. If we are not conducting a conference or there's nothing like that, then we definitely will have a journal club. So Tinsley Harrison had his own journal club. So you can very well imagine what's the importance of a journal club. This is for critical evaluation. He used to hold it twice a month. It is said that the discipline is very important. So I request both the speakers to stick to their timelines. And of course, healthy skepticism or praise is most welcome. This is a bit about me. I'm working as a spine and pain physician at Mumbai. And of course, today we have with us our expert faculty, Dr. Ravi Krishna Kalathur, who has done his MD in anesthesiology, or rather, let me introduce him later on once he's there in front of him. I think right now he's not joined. So over to the speakers. Let's go straight to speakers and start with the presentations, and I'll introduce the faculties in a while. So Dr. Sneha, you can start sharing your screen and put up your CV slide so I can just introduce you, and then we can go on from there. So please click on the share screen. Yeah, I can see your screen. Great. Can you make it full screen? Just click on the play button and you'll be done. Yep. So can you click on the play one? Yeah, great. So put on your CV slide so that I can just introduce you. The next one.
Sir, this participants are not able to move it.
So you just click on the screen
Okay.
And then, yeah, click on, yeah, of course, great. So Dr. Sneha Shreyas has done her DA, DNB, FIPM, and she's a medical director and consultant pain specialist at the PainX Advanced Pain Management Center at Bangalore, and also anesthesiologist at the Men's Hospital in Bangalore. So over to you, Dr. Sneha, for a crisp presentation. Thank you.
Thanks for the presentation, sir. Good evening, everyone. Today, the journal allotted to me is about the importance of musculoskeletal ultrasound, musculoskeletal interventional ultrasound in the upper limb. This has been published in 2012 in Diagnostic and Interventional Imaging by Williman V, Guerini H, and Morvan G, all are from Paris, France. Coming to introduction, the use of ultrasound has led to tremendous advancement in the field of pain medicine, and ultrasound has become an indispensable tool in pain medicine. It is commonly used for diagnostic imaging, and now it has expanding roles in therapeutic application also. Like coming to the major advantages like patient safety, precision, and success rate, all have been increased now because of the ultrasound guided interventions. The primary aim which has been defined in this journal is basic aim of interventional ultrasound is injection of therapeutic substance into the target area or specific site. The authors have defined the target area being our specific area of interest, and therapeutic substance could be either hyaluronic acid or corticosteroid. So coming to the methodology, this study is a retrospective observational study where they have collected data of the patients over 1.5 years duration. All 823 ultrasound guided procedures which were undertaken over 19 months. So all these cases involved upper limb, and all these required injection. Coming to the statistical analysis, in that they have found shoulder area to be the major upper limb site, being 24%, and the next is subacromial bursa, that is 79%. And calcific tendinitis being 13%, and then acromioclavicular joint and sternoclavicular joints being 6%, and sheath of tendon of long head of biceps being 2%. Now, coming to the procedures which were performed in the hand, wrist accounts for totally 8%. In that, tendon conditions account 59%, and majority is dequervine stenosynovitis. The next comes rhizarthrosis being 28%, carpal tunnel syndrome is 8%, and ganglion cysts account for 5%. And the procedures which were done with finger involvement totally constitute about 6%. In that, trigger finger constitutes 75%, tenosynovitis 8%, pulley ganglion 10%, and the joint involvement per se 8%. Coming to the elbow procedures, which is the least in the upper limb, that is 2.5%. In that, in elbow, the highest is the tendon involvement, that is 60%, and ulnar nerve compression constitutes about 30% of cases, and bursitis being 10%. Coming to role of ultrasound, which has been defined in this journal, to select pathological structure to be injected to the target the area to inject, to avoid intratendinous injection, injecting at periphery and in contact, injecting into the bursa or cyst cavity to avoid damage to the adjacent vessels and nerves. It involves continuously monitoring the path of the needle during the procedure and monitoring the distribution of the drug during the injection. Coming to the fingers, first is trigger finger. It is stenosing tenosynovitis of flexor tendons of the fingers. It is related to thickening of A1 pulley, which overlies the metacarpophalangeal joint. It occurs most frequently in thumb and fourth finger, and the usefulness of guided injection has been proved by several studies. And ultrasound guided injections are known to be 70% effective, as it is exactly into the actual sheath. Only 15% of the injections when done blindly goes into the sheath. No occurrence of any intratendinous injection when it is done under ultrasound guidance. And 1 year data, ultrasound guided injections have given 90% good results. 90% of the cases had symptom disappearance noted after single injection, and 44% cases only had a good symptom disappearance in blind injections. Ideally, according to the authors, 2 injections should be offered to the patient before considering surgical management. And in the trigger finger, coming to the technique, first important is the positions. As we all know, ergonomics play a very important role for any interventional pain specialist. So we should make the patient comfortable with arm relaxed and hand lying flat over the table. And ideally, we should use a hockey stick probe, which they have called it as pencil probe or golf club probe. And for the trigger finger, usually fine needle is recommended. And usually steroid in low doses is used. This is the diagram which shows hypertrophy of the A1 pulley at MCP joint, which is the hallmark in the trigger finger. And the advice and hints being axial approach is used, avoiding the neuromuscular bundle for thumb, and sagittal approach can be used for other fingers. Post-procedural recommendations, rest is advised for 48 hours and no immobilization is recommended usually. Coming to the next condition, that is polyganglia, which accounts for 70% of the finger swellings. This most common occurs in women and usually occurs near A1 and A2 pulleys. Ultrasound is very essential to confirm the cystic and non-tissue nature of the swelling before the injection. And in polyganglia also, the authors recommend 2 ultrasound-guided injections to be offered to the patient before envisaging surgery. Complications of the surgery being annoying scar, damage to neurovascular pedicle. So all this can be avoided by ultrasound-guided injection, and recurrence after percutaneous treatment is very high, being 23 to 35% of cases. In the ultrasound picture, we can see hypoechoic lesion over the flexor tendon. And the advice and hints for the polyganglia approach to the cyst is usually direct. If possible, the contents are aspirated and removed, and corticosteroid can be injected. And post procedure, relative rest for 48 hours and no immobilization is recommended. Coming to tenosynovitis, all tenosynovitis, both inflammatory and non-inflammatory, may be treated by ultrasound-guided injection. Contraindications for this procedure being suspected acute and chronic infection, purulent inflammation of the sheath, infection by slow-growing organisms or mycobacteria. In tenosynovitis, advice and hints being the approach is always sagittal in the axis of the finger and the tendon. Depending on the location of the liquid and thickness of the sheath, proximal or distal recess of the sheath is approached first. Check correct peritendinous distribution of the steroid near injection site and also along the whole length of the sheath. And post-procedure, as in any other procedure, relative rest is advised for 48 hours and finger is usually splinted to adjacent finger. Coming to the wrist dequervence tenosynovitis being the most common. This is a mechanical tenosynovitis. It is related to thickening of retinaculum of first dorsal compartment of the wrist. That is abductor pollicis longus and extensor pollicis brevis tendons. It constitutes 2 clinical forms, type 1 without any septum in between the 2 tendons, and type 2 where there is a thin septum which separates the 2 tendons, or it could be also isolated constriction of EPB, that is extensor pollicis brevis. And it is essential for therapeutic management to be aware of these 2 forms. The failure rate for unguided injections is approximately 20%, and it is thought to be due to the presence of the septum. In type 1, injection can be done under the retinaculum into the sheath of the 2 tendons. In type 2, with ultrasound guidance, the sheath of the extensor pollicis brevis tendon can be targeted exclusively. And we need to check for the steroid distribution into both subcompartments. Dequervence type 2 with the presence of the septum is seen in this diagram, and thickening of the retinaculum is localized around the extensor pollicis brevis tendon. And in the intervention, position the patient comfortably in dorsal decubitus position. Wrist should be resting on a wedge with slight ulnar inclination. Both the approaches, sagittal or axial, can be used. Advice and hints: when septum is present, axial approach is preferred, so drug gets distributed to both the subcompartments. Sensory branch of radial nerve passes superficial to the retinaculum, so it must be located and avoided. And in the cases of constrictive tenosynovitis, injection under the retinaculum is difficult. Such cases, it is injected proximal and distal to the retinaculum. Coming to the carpal tunnel, it is most favored by ultrasound diagnosis, which shows the disparity in the nerve caliber, surface area of the nerve being more than 12 millimeter square, modification to ultrasonic structure, hypoechoic nerve with hyperemia on Doppler, degree of flattening and bulging of the flexor retinaculum, presence of persistent median artery, which can be seen in 20% of cases. We need to look for any other etiology and local anatomical variants. And the technique of the intervention: place the wrist in slight dorsiflexion. Two axial approaches are possible. Ulnar route is recommended. Distribution of the corticosteroid should be done around the nerve to elicit the target sign when we inject around the nerve. Radial route to avoid radial artery, which passing under the radiocarpal flexor, has been proposed. Wrist splint is advised for 48 hours post-procedure. Coming to ganglion cysts, synovial cysts account for 60% of tumefactions of wrist and hand. 95% of cases show characteristic ultrasound appearance is partitioned anechoic structure. Walls appear little vascularized or non-vascularized with Doppler. They communicate with adjacent joints via a hole, so it should be sought carefully by ultrasound. Aspiration and injection is proposed before considering surgical treatment. And the technique for ganglion cyst intervention: the approach depends on the location of cyst. Axial or sagittal approach, depending on the size and anatomical structures, to be avoided. Radial and ulnar arteries should be located and avoided. Advice and hints being: the contents of the cyst can be thick, so it is better to use a large caliber needle, and lavage of the cyst should be done with lignocaine if possible. And now coming to the forearm, the most common is the intersection syndrome. In proximal intersection syndrome, it is the point where myotendinous junction of the first compartment tendons, that is abductor pollicis longus and extensor pollicis brevis, crossover with the second compartment tendon, that is extensor carpi radialis longus and brevis. Clinically, the picture of bursitis can be seen with pain and tenderness elicited over the tendons. And in ultrasound, we can visualize peritendinous edema, hyperemia under color Doppler. In coming to distal intersection syndrome, usually pain in the distal forearm and the point where second compartment tendon crosses over the third compartment tendon, that is extensor pollicis longus. In ultrasound, again tenosynovitis of two tendon sheets can be seen. And in the intersection syndrome, coming to the technique, for proximal intersection syndrome, the approach is dorsal and axial. It is 10 centimeters above the radial styloid process. Coming to the distal intersection syndrome, the approach is at the level of radiocarpal joint. Advice and hints: the needle is repositioned into each tendon sheath and steroid is injected. Post-procedure recommended to rest, and wrist splint is advised for 48 hours. Coming to the elbow, epicondylitis, lateral epicondylitis or the tennis elbow, which is the most common, has been explained. Damage to the this tennis elbow involves damage to the common extensor tendon, and ultrasound diagnosis is the key. And we are aware of the ultrasound features which are seen usually in the tennis elbow. And cortisone injection is known to provide short-term relief. And the technique is dorsal decupitous with arm resting on the table, and elbow should be flexed at 90 degrees. Approach for the intervention: longitudinal, should be done in long axis of the tendon. Usually, we need to use a fine needle parallel to the subcutaneous plane. And the tennis elbow, advice and hints: tenotomy can be done, that is perforation of the tendon at multiple points, so that it will promote healing. And post and treatment recommendation: rest and stop the sports activities for at least 10 days. Coming to cubital tunnel syndrome, it is the compression of ulnar nerve in the cubital tunnel. Cortisone injection can be planned, and the position for the intervention is in ventral decubitous position with arm flexed in internal rotation. The approach is axial to the cubital tunnel. Coming to the shoulder, first common is the subacromial bursa, that is the inflammation of subacromial bursa, and with landmark guided injection, 15 to 70% of the injected doesn't go into the subacromial bursa, and X-ray guided intervention should be abandoned due to risk of irradiation and sensitization to contrast agents. And the diagnosis by ultrasound again is highlighted in the subacromial bursa. For the intervention, the position of the patient should be in dorsal or lateral decubitus position with the arm placed in internal rotation and hand along the side of the thigh. Approach is anterolateral. Steroid is usually injected between the layers of subacromial bursa. Advice and recommendation: xylocaine is injected superficial to bursa. Usually advised to rest for 48 hours and no sporting activities for 1 week. Coming to the next common condition in the shoulder, that is calcific tendinitis. Ultrasound guided treatment is preferred over radio treatment. The advantages again being it avoids radiation exposure and the better clinical results. Needle is monitored in real time and we can predict consistency of the calcification depending on attenuation characteristics, and it evaluates whether the calcification is favorable for fragmentation. Coming to the technique of the intervention, a patient is positioned in dorsal or lateral decubitus position with arm internally rotated. We need to bring the calcification clear of the subacromial space and approaches anterolateral. Calcific tendinitis, in this condition, advice and hints: this is done in 4-staged procedure. First, injection of anesthetic into subacromial bursa, puncture, then gradual fragmentation with the needle, monitoring the changes to the calcification, injection of corticosteroid into the subacromial bursa, warn the patient about increase in pain. We need to prescribe analgesic and advise cold compression. Coming to the AC joint, this is often forgotten cause of shoulder pain, so it should be investigated as a part of systemic examination of any painful shoulder. We need to look for synovitis around the joint space. Technique, we need to position the patient in dorsal decubitus position, approach being antero-posterior and direct. Advice and hints: visible distension of articular cavity, it confirms the intra-articular injection. Coming to the conclusion, integration of ultrasound in pain management has proven to be a game changer. It offers a non-invasive and precise approach to diagnosing and treating various pain conditions. Real-time imaging capabilities allow for accurate needle placement. It increases the effectiveness of interventions while minimizing risks and complications. Embracing the potential of ultrasound paves the way for advancement in the branch of pain medicine. However, limitations are accepted as this statistical study might be done by radiologists. The data might not correlate so much, and more importance has been given to ultrasound findings and the interventions, and clinical diagnosis is not much highlighted in this study. Coming to critical analysis, radiological analysis. So as I mentioned, importance is given to ultrasound findings. There is no inclusion or exclusion criteria which has been well defined in the study, and as this is a retrospective observational study, observer bias is expected. Randomized control study has to be done to evaluate the efficacy of the interventions. Take home message: again, ultrasound is the best modality to evaluate and treat many musculoskeletal conditions in upper limb, and it's definitely the best tools in hands of any pain physician. We need to expertise and make the best use out of ultrasound. However, clinical diagnosis always comes first. Thank you.
Thank you, Dr. Sneha. Now over to Dr. Sinduja for the next talk. Dr. Sinduja, can you start sharing your screen and put your CV slide so that then I can introduce you. No, put your CV slide. Yeah, okay. Can you switch on your video? I think your video is off. Not knowing. Yeah. Okay, now it's on. Good. So thank you, Dr. Sneha, for the crisp presentation. Now we come to the second presentation for today, which is by Dr. Sinduja V. She's done her MD and DNB in anesthesiology from Dr. VMGMC Sholapur. She's the current fellow in pain medicine at the DY Patil University, Navi Mumbai. Over to you, Dr. Sinduja.
Thank you, sir. Thank you for such a nice introduction. Okay. Today, we'll discuss about the topic of an ultrasound-guided hydrodissection of cervical nerve roots or cervical radicular pain in patients with mild and moderate to severe stenosis, a retrospective cohort study. Introduction. Ultrasound-guided nerve root blocks. Ultrasound-guided nerve root blocks are used for treating patients with cervical radicular pain. Facial entrapment neuropathy can occur in multiple locations. The effect of a block in a specific location may only partially relieve a patient's pain. So a nerve hydrodissection involves injecting a large volume of solution into areas of suspected compression to release the compressed nerve. The most commonly used injected are normal saline and 5% dextrose in water, and we sometimes use platelet-rich plasma. And the aims and objectives of the study is to study about the advantages of cervical nerve root hydrodissection and its outcome in patients with cervical entrapment neuropathy. The methods, which includes inclusion criteria such as cervical radicular pain that has lasted for more than or equal to 3 months and limited pain relief even after 1 month of physical therapy and analgesic drugs. The exclusion criteria are prior cervical injections within 6 months, history of cervical surgery, cervical malformation, systemic lupus erythematosus, Sjogren's syndrome, rheumatoid disorders, and a follow-up period of less than 3 months. In this study, they have enrolled a total of 74 patients who were divided into 2 groups. The group 1 comprised of 44 patients with mild stenosis and a group 2 which comprised of 30 patients with moderate to severe stenosis. In this, the patient is made to lie supine and the neck is externally rotated to 30 to 40 degree and the part is prepared, clean and draped, and after that, using a linear ultrasound probe, a C5 to C8 nerve roots were identified and a 50 millimeter 23 gauge needle was inserted from posterior and directed anteriorly towards the nerve root. As you can see in this figure, the patient is made to lie supine and head towards the opposite side, and the nerve needle is directed from posterior to anterior using the in-plane approach, and a 10 ml mixture of 5% dextrose, 0.2% lignocaine, and 4 mg of betamethasone was injected to hydrodissect the nerve root. The patients received 3 consecutive injections at 3-week intervals. In this figure, you can see figure A shows the anterior and posterior tubercle of the C6, and this is the C6 nerve root. And in this figure, you can also see that a needle approaching towards the C6 nerve root. And in this next picture, you can see that the needle has almost reached the dorsal side of the nerve root, and the hydrodissection may have started. And in figure D, you can see that since the dorsal side of hydrodissection is done, we have to separate the nerve from the ventral side, and since that's why we have put the needle into the ventral side and doing the hydrodissection of the entire C6 nerve root. So the primary outcomes of this study were a study based upon these, as the reduction of pain in neck and shoulder and upper limbs, and on numerical rating scale was used to quantify the pain reduction, and the proportion of patients who exhibited a favorable outcome were calculated at 4 time points at 1 week, 1 month, 3 month, and final follow-ups. And the results are, this is a patient selection criteria. There are 85 patients selected, of which the patients with 48 had mild stenosis and 4 were lost to follow-up, and therefore the 44 patients were included in the study. In moderate to severe stenosis, there were 37 patients and 7 were lost to follow-up, and therefore they had 30 patients to study. And this is the patient characteristic table, which includes the number of patients with mild stenosis and number of patients with moderate to severe stenosis. And according to numerical rating scale, their pain in pre-treatment was 6.4, and this moderate to severe stenosis had a pain rate of 6.7. So target nerve roots were totally they targeted 96 nerve roots in mild stenosis and 75 nerve roots in moderate to severe stenosis, and of which the most commonly targeted nerve root was C6. As you can see here, the number of nerve roots blocked were 40 C6 nerve roots and 29 in moderate to severe stenosis, which was the highest when compared to all other nerve roots. And the total number of patients who received this is 44 and 30 patients. And the length of follow-up were given in months, which was mean plus or minus ST, which was 5.5 months plus or minus 3.8, or 4.7 months plus or minus 3.1 in moderate to severe stenosis. So the results of this study were given as a chart and numerical rating scale. As you can see, the patients with mild stenosis and moderate stenosis are marked in a gray and a yellow zone. The pre-treatment numerical rating scale was near about 7. And after the injection, there was a significant reduction in the numerical rating scale in the first week, and gradually the numerical rating scale has reduced till the final follow-up. And one more thing is the mild stenosis patient had a greater reduction in pain scale when compared to the moderate to severe stenosis. So the favorable outcome proportion is also given for both the mild and moderate stenosis patient. So mild stenosis patient, they had a good reduction in pain, and moderate stenosis also had a good reduction in pain. So finally, they have given a conclusion that irrespective of mild or severe stenosis, hydrodissection of cervical nerve root gives a good pain reduction. On discussion, the patients who underwent ultrasound-guided nerve dissection of the cervical nerve roots exhibited significant improvements in pain reduction, and the magnitudes of the improvements were similar in the patients with mild and moderate to severe stenosis. Results indicates repeated injections after the initial injection is the most important factor. Repeated injections performed at 2 to 3 weeks after the initial injection contributed to prolonged clinical benefits in patients of pain reduction. So on this discussion, we are going to see about the patients who exhibited a favorable outcome on the final follow-up. In group 1 mild stenosis, 34 patients exhibited a favorable outcome at the final follow-up, and in group 2 moderate to severe stenosis, 19 patients exhibited a favorable outcome, and in which the patient who did not exhibit favorable outcome were 10 patients who did not exhibit a favorable outcome of mild stenosis, and 11 patients who did not exhibit a favorable outcome on moderate and severe stenosis. So this is the risk factor analysis between the favorable outcome and unfavorable outcome at the final follow-up. So these patients were the favorable outcome. These are the unfavorable outcome patients. So based on that, these 34 patients of mild stenosis exhibited a favorable outcome, and 10 did not exhibit a 10 did not exhibit a favorable outcome. So the number of injections also varied on these patients. So 9 patients who had 1 injection exhibited a favorable outcome, and 12 did not exhibit a favorable outcome. So likewise, the list goes on. On discussion, the patient reported elevated pain immediately after the initial injection. 51 patients exhibited a favorable outcome within 1 week, and 56 patients reported a favorable outcome at 1 month, which indicates that the pain was gradually elevated in some patients. Pain reduction did not differ significantly between the patients with mild and moderate to severe stenosis. Conclusion: ultrasound-guided nerve hydrodissection of cervical nerve roots is a safe procedure that reduces pain associated with cervical radicular pain, even in patients with moderate to severe stenosis. Similar outcomes in both selective nerve block and hydrodissection. 10 ml mixture of a single level of 5% dextrose, 0.2% lignocaine, and 4 mg of betamethasone is appropriate for nerve hydrodissection of the cervical nerve roots. Hydrodissection of multiple cervical nerve roots can be performed when a patient's symptoms are not attributed to a specific nerve root. The limitations accepted were the matched group design was not employed, which decreased the comparability of the groups. A control group that underwent conservative treatment was not included, hence the treatment effectiveness cannot be assessed. Considerable variation in the continuous data was observed, which indicates that the mean values for each variable may be inaccurate. A longer follow-up period would be needed to investigate the long-term results. The findings should be verified through the studies with a larger sample size. Critical analysis. A larger sample size was required for efficacy estimation, and as this is a cohort study, there could be an observer variation. Take-home message: ultrasound-guided cervical root hydrodissection reduces pain in patients with cervical radiculopathy. With enough knowledge and practice of ultrasound, even in patients with moderate to severe stenosis, hydrodissection can result in reduction of pain. Thank you.
Great. Thank you, Dr. Sinduja. I think you can click once more to exit your slide, and we can just stop the screen share. Now we have to, I'll just introduce the faculties which are now present. So please allow me a moment to share the screen. I think you can see my screen now. Guys, please type yes in the chat box if you can see my screen. I will just like to introduce our faculties. Today we have with us Dr. Ravi Krishna Kalathur. Welcome, Dr. Ravi. I think I say hi.
Thanks. Hi, guys. I enjoyed the I joined a bit late. Sorry. I enjoyed Sindhu's.
Oh, you were hardly 5 minutes late, I think. That's good enough.
Sorry
So
about that.
yeah. So I'll just introduce you to those. I think you're already well known, but still. So you are Dr. Ravi Krishna Kalathur is the head of department for Department of Anesthesia and Pain Management Services at Apollo Hospitals, Greams Roads in Chennai. He's also the director of Chronic Pain Clinic, and he holds, I think, a plethora of qualifications, CIPS, FIPP, one of the most difficult qualifications to achieve, and also ultrasound in rheumatology by ULAR, and also has been the CIPS examiner of the WIP United States and invited faculty for various conferences all over the world. So welcome, Dr. Ravi, once again.
Thanks.
And
Thanks.
our second faculty, so our second faculty is Dr. Sanjog Mekewar. He's done his DNB and FIPM, and he's currently working as consultant intervention spine and pain physician at Sahyadri Hospital, Pune, Sainath Hospital, Pune, AJCT Hospital, Pune, the various hospitals in Pune, and also BJ Medical College and Sassoon Hospital in Pune, as well as he's director of GV Shah Pain Management Center. His area of interest include region med and spine endoscopy, and he's got a number of publications in various journals, and he's avid traveler explorer. Welcome, Dr. Sanjog. Are you there?
Thank you, sir. Thank you, sir, for the introduction.
So I think over to both of you for any questions or and the audiences. I request you to please type in questions in the chat box, or also those of you who are joining in from YouTube, you can type as comments, or Facebook, type as comments, or Instagram, please type as comments, and I will just put it up here. So I think over to you guys. I will just stop the screen share and let the discussion happen.
Sindhu, my question in this, when was the study done? How many years ago was this?
Sir, I think it was very long back, 2017, I guess.
So one of the biggest things that I realized is these pictures which you put up, the C6 tubercle. The C6, for some reason, there was no anterior tubercle.
Okay.
So did you pick up this picture from the study, really?
I took this from the article, sir. It is a picture.
From the same article? Okay.
Yes.
Sorry about that. So that is one of the things. Next thing, in terms of terminology, I think it's unfair to call it cervical root injection. One. It's a bit. It's a periradicular injection, extraforaminal injection. In some of the cases, it was extra fascicular injection. After it is divided also. Okay. I saw 2 pictures of you in that study there. So one thing is, if you realize that the pain scores between the mild versus
moderate to severe stenosis.
Sir, actually,
do you agree?
Your screen is freezing, and it's like maybe you can switch off your video and just speak out. I think.
So I'll do that. Sorry. So in terms of, it was interesting to see that the mild stenosis versus the severe stenosis both had the same pain scores.
Okay. Yes, sir. Yeah. Yes, both had like a 6.5 and 6.7.
Okay. That's a bit weird, anyways. And this radicular thing, whatever I possibly to add more to this is one, the injection site. C6 is the very most common radicular radical that is generally stenosed. That is almost very consistent with your study also, with the study that you quoted.
Yes.
But what my interest was, how much proximal to the nerve root were these people trying to access?
They
One.
have just
That's
given
one
that.
of the questions.
Yes, sir.
And if okay. Sorry.
Sir, I can't get it.
Please carry on.
Sinduja, you can speak whatever you want.
Okay.
He's waiting for you.
Sir, in this study, they have just given that they have one pain physician who is performing the block on all the patients. So in order to avoid the bias, they have not given as to how proximally he has given the injection.
Yeah. So one way to negate that problem is, in case you are doing it if you are extrapolating it to your practice, would be to combine it with a fluoroscopy model.
Yes.
So just go as much. Usually you go posterior to the radical, meaning you avoid the anterior part of it. Go towards the posterior side of the foramen. I mean, closer to the. If suppose you see the nerve root as one, say o'clock, it should be anywhere between 5 to 7 o'clock.
Okay, posteriorly.
So posterior to the root. So basically, and then when you inject the dye, you switch on the fluid. Ideally, switch on the DSA if you have, especially if you're injecting any steroid, non-particulate generally. So ideally, try and switch on the fluoro, switch on the DSA if you have. Otherwise, even if you don't have DSA, switch on the fluoro and see if there is a medial spread.
Okay.
If you're only doing an extraforaminal injection, I think this particular study itself defeats itself. So what is the? I mean, it is like doing a peripheral nerve block.
Yes, sir.
So even if there is a mechanical effect of hydrodissection and whatnot, we would like it to go so medial most, rather than anywhere between the dural sleeve. I mean, into the dural sleeve side, not away from the foramen.
Okay, sir.
So extension
in your practice, I think if you really want to do this, identify the level properly. Yeah, sorry.
Sir, continue. You first finish, sir.
Yeah, so I thought if you are choosing this injections, a couple of things that you will keep in mind would be identification of the level. If it is C6 and you're examining the C6 root symptoms and relief of symptoms, please make sure you're in the right place. Meaning, if it is C6, the anterior tubercle is very, very prominent. And in your particular thing, I thought the needle tip is in the C7 because there was no anterior tubercle.
No anterior tubercle.
Okay.
Or a very rudimentary kind of a anterior tubercle. So that is the rule number one. Next, go as close to the root as possible. I mean, wherever the new nerve root is exiting out. Next thing is anywhere between 5 to 7 o'clock. That's one more thing. And then you can switch on the fluoro, do it as a hybrid procedure, and then inject the dye, see for the medial spread of the dye.
Okay.
That would be a great way to do for your thing. See, apart from this particular study, if we have to pick up something, I think that is what we need to pick up.
Yes, sir.
And never, I mean, you can still go with anterior, but anterior is where the venous plexus and the arterial radicular vessels are. So ideally, stay away from the anterior side.
Okay.
That means if the root is dividing the anterior tubercle and the posterior tubercle space, the posterior tubercle space is where your needle tip should be and not the anterior tubercle space.
Okay, sir.
So you can still have vessel. If you are unlucky to have a vessel, it would be venous plexus, not a radicular, general.
Okay.
So I think if you combine all these things and your checklist has this, you can still get a good yield onto your patient.
Just extension,
So
just extension to this
yeah,
question is how they,
yeah.
Sinduja, how they decided on the volume, 10 ml volume that they are injecting, and is it per level 10 ml? Like if some of the patients they have injected in multiple levels, C5, C6, C7, right?
Yes, sir.
So they are injecting 10 ml per level, or it is the total volume? What is it?
10 ml per level, sir. If they are injecting on one level, it is 10 ml. If they're injecting on multiple level, also it is 10. Volume is 10 ml, but they are reducing the dose accordingly. The
They are
dosage is
reducing the
reduced.
total dose.
Yes, sir.
Okay. They have not mentioned what is the total dose of steroid that they have given, or
No, sir. No, sir. They have just mentioned that even if they give multiple level, the dosage is taken care of.
okay, okay. Because I have done this, just what Ravi sir had just mentioned, that confirmation with contrast and that hybrid method I have done. And I've
Yes.
seen that even 2 ml of contrast, if I push and it just goes inside and we can see it in the epidural space. But when we are doing the same thing in the patients with severe stenosis and all those things, in those patients, obviously, if there for even after doing the interlaminar epidural, we have seen that many a time because of the stenosis, the contrast is not going outside the foramen. So in those kind of patients, if our drug is not actually reaching the point where we want to give, I think so that we have to confirm with this contrast. Actually, where is the drug going? And then only we can comment, is it working or not? That is the second.
Yes. True.
Yeah. See, the resistance, see, the fluid moves wherever there is least resistance.
Least resistance.
So remember that the medial side, if it is stenotic there, if the medial side is the stenosis is really profound, the whatever 10 mils that you are giving, if it is lidocaine or even plain normal cell line, very unlikely that it would spread medially. So the best indicator for you to do it is with a dye injection, especially if you're say if you're doing in your scope of clinic, if you are doing say C3 or C4 for example, C4 route for example, wherein maybe not exactly a stenosis, if imagine if it is a post-hepatic neuralgia or something like that. So and then you want to do a C4 injection. So say C4 injections, C3 injections, and so on. Never ever do it with only ultrasound. Make sure you do it with an addition. You do a hybrid procedure. That's always a safety index that you will definitely appreciate it as soon as you do a lot more volume.
Yes.
So on an average, we do 2-3 per at least 2-3 per month. You do an interlaminar, it's really not yielding so much into that particular radical. You get a good heavy hands, but then the C6 radical alone is not really getting better. Still the same thing. So you would be tempted to come and take him back into the theater and then do a ultrasound, periradicular injection. Now these terminologies have changed because it is not a transforaminal injection or a root injection. These are periradicular injections and extraforaminal injection. So let us be clear in terms of our understanding of this particular injection. And ultrasound is all about precision, as you said. And as Sneha was mentioning, it's all about precision. So I don't know if you have more comments, observations, or questions. I'll be wholly happy to intervene and answer that.
I have one question for Ravi sir. I have one question. What is your take on that combination of 5% dextrose and steroids? The combination of these two things.
Yeah. So see, ideally, I don't know if you've read the recent edition of RAPM. So there was an article which said that do you really need a steroid to inject with lidocaine? So all these things, whether you need lidocaine or 5% dextrose, I think you're looking at the mechanical Decompression really.
Decompression. Okay.
But what I do is with lidocaine. I do it with lidocaine.
Nothing else. Plain light.
So I don't know if I've answered your question, Sanjog, but this is what I do.
Okay. No, there are a lot of people have a lot of take on this actually. Someone is only doing with 5% dextrose plain. Somebody is doing only steroid.
Yeah.
Somebody is doing only lidocaine. Somebody is using now. Some people are using combination of this 5% dextrose and very low doses of steroids is what they are saying.
Correct. See, I see. If you look at the studies, the recent literature that I mentioned earlier, about a month back, do you really need to add steroid in your epidural space? So the shift is moving away from the steroids now.
Okay.
So if you are talking, I use a preservative-free lidocaine one. If I see that the scar tissue is there and I don't like the echogenicity of the nerve root close to the radical and really where it is coming out, if I don't like it, I would be tempted to use more volume. Let's say if I want a 5% dextrose, I will do it. But it's not a norm, that is. And the best thing is when you observe this under the scope, under the ultrasound.
Yes.
So it is not a blanket rule, but then as you go in, when you first inject the lidocaine, and when the nerve root is showing up, how the fluoroscopy picture is showing up, all this will determine even the volume. This 10 ml is a bit too much.
Yes.
It's a bit too much.
Yes.
But each level to 10 ml is a lot actually.
Yes.
So
that's why I asked how much volume are we injecting?
Poor Sinduja has nothing to do with it. There's somebody in Korea who did this. I mean, poor thing. What can she do? And it was 6 years ago. Cervical nerve root injections were just coming back into play from. See, we stopped cervical transforaminals or nerve root injections because we were doing predominantly fluoroscopy based. So since the efficacy versus the benefit versus the risk was so bad that the risks outweighed the benefits. So they actually gave up on fluoroscopic guided cervical transforaminal injections. Now, only with the ultrasound, people realize they can still go and reach the nerve root somewhere. So after maybe 16, 15, or maybe even 14, people started to understand that we can also reach from the foramen now with ultrasound. So that is when these studies would have become slightly more motivational, aspirational, or maybe encouraging, or maybe even fashion also. I don't know.
Great. So I think thank you both of you, Dr. Sanjog, Dr. Ravi, for the excellent discussion. Dr. Sinduja, Dr. Sneha, do you want to ask anything or you want to discuss anything? This is the time before I put up a couple of audience questions and we end the session.
By the way, it was nice meeting you guys after about a month and a half again. Sindhu and Sneha, I think I met you guys there. And it's been pleasant to see you guys.
Same.
You can ask the questions. I didn't want to deviate this, but please ask questions if you want.
There in the study which like in this journal also which I presented, everywhere they have mentioned only steroid. No dextrose has been mentioned. Maybe because this is 10-year-old, 2012 it was published. So maybe the same reason implies here also, right? Everywhere, even in the carpal tunnel, now recent studies are coming up with avoid steroid and use only dextrose hydrodissection. So here, everywhere, only steroid is mentioned.
Yeah. It actually RIPM actually published last month. So we will move. We are seeing a significant change movement away from the steroids.
Great. So I think let's quickly take up one question, which is a very generic one from Dr. Shekhar Kognulkar. He's asking, does anesthesiologist get permission for using a portable ultrasound along with him? So the answer to this question is certainly not. And if he's residing in India, so not even an anesthesiologist, nobody can get permission for using a portable ultrasound. This is actually because of the PCPNDT Act, which is there, and
Correct.
I will request
But
you to
I
kindly.
have something. See,
Yeah.
first, I don't know what he's speaking. I think he's talking about point of care ultrasound or pocket-sized ultrasounds. If it is
So any
pocket-sized,
ultrasound, I think any ultrasound, if you want to move from the place where it is registered
no,
to somebody,
you cannot.
yeah, so you cannot do it.
You cannot do it.
Yes. However, in the OT, like for example, it is registered for the OT complex, so you can move it from one OT to the other. In fact, it is so specific that you can't even move, floors and all. So you be very careful.
Yeah.
It has to be wherever you want to use. It has to be mentioned on the PNDT certificate.
The PNDT certificate itself will give you areas where it can be placed.
There it
One,
can be.
wherever it is placed, you need that particular sheet
Permission.
of screen saying that we don't do gender
Yes.
determination, and there is a special form which is there which you have to fill up. All this is better avoided. Shifting of ultrasounds, especially, and you don't sell nobody sells pocket-sized ultrasounds, though it's available. We don't.
We have
They don't
a
sell it
couple
in
of
India.
models which are now coming up in India with
Mhm.
a couple of, I think, some butterfly.
Butterfly is there for the past 15 years, Siddharth. But what is happening is, even when they come to India, it's a Hong Kong based, China based product. But what happens is, it was a laptop based model earlier. So world over, it's available as a laptop. But in India, they have to make a stand and sell it. So that is the difference.
Yes.
So they have to modify themselves and sell it to India. That much I'm pretty sure.
No, it's definitely correct. Because when I purchased the one for my clinic, and I think Dr. Sinduja also has it. So, and of course, you also have a lot many in your department. So I think we have to go through a specific procedure, which is very, very clear, and the penalties are very stringent. So
Oh, that's not worth it. No, I don't personally own Butterfly. I worked on Butterfly in CHK, the Hong Kong hospital, about 14 years ago. So I don't have a Butterfly in Apollo. No, I don't have. You guys are forward in having it. I don't have it.
So great. I think thank you all for the excellent discussion. If there are no more questions with all of your permission, I'll just end the discussion here. Thank you for Dr. Sinduja and Dr. Sneha for the excellent presentation, and thank you, Dr. Ravi and Dr. Sanjog, for your presence and your time with excellent moderation. So we now end this particular journal club, and as we all know, this is the season 4 of the Mumbai Pain School's Pain Journal Club, and this season we are focusing on MSK Ultrasound, and we have an 8 p.m. Indian time on Fridays. We have grouped the topics for seasons, and of course we have 2 faculties, 2 papers format, and we send the papers one day in advance. And the next steps for those of you who are attending is just join our mailing list, and we have put in the WhatsApp group. Any suggestions, comments are most welcome and valuable for us. Please mail them to me at mumbaiPainSchool@gmail.com. And of course, let's meet on next Friday, 8 p.m. with a new topic. And those of you who want to, do some hands-on course, or rather a workshop, these are the dates for our next hands-on MIPSIS workshop. So the links for registration will be out soon. Looking forward to seeing you all very soon. And thank you all once again for joining in. So we are signing off here, and see you next Friday at 8 p.m. Good night, guys.
Thank you, sir.
Good day, guys.
Thank you all.
Good day.